Hi, everyone. I'm Samira Daswani, the host of the podcast, The Patient from Hell. This is another episode that has been funded by a grant that we got from the Patient-Centered Outcomes Research Institute, or PCORI. And I have with me a PI, or a principal investigator, who was also funded by the same institution, PCORI, and has been doing research in the world of oncology, as well as practicing medicine in the world of oncology for many, many years. And it is my utmost pleasure to welcome Dr. Mohile to our episode today.
Yeah, thank you so much for having me today, and congratulations on securing a PCORI funding for this podcast project. It's not easy to get PCORI funding. It's actually quite difficult. And so we're in both, people who have achieved that level of success. So congratulations.
Thank you. I super appreciate it. I don't think we fully realized what we were getting into, to be honest, but
No, there is a common phrase that it's not about getting the grant, because like once you get the grant, it's the work has to happen then. So we are all like thinking about writing the grants and getting them, but it's really the hard work is after.
no, it's totally true. I feel very grateful because through the grant, we've gotten to meet people like you and
Mhm.
researchers like you. So it's actually been very, very fun for me. We
That's
just weren't
great.
ready for the pace.
Yeah. Yeah, no, they're milestones. You've got to meet them for PCORI. They keep you on track.
Um, so actually, with that, maybe we can jump right in since we're talking about it.
Sure.
I would actually love to start with your personal background.
Sure.
So
Yeah.
you're
So
doing
yeah,
doing both, right? You've been in the research side and the clinical medicine side. So I'd love for you to talk about why do both? How did you get into it? Just a little bit more about you as an individual would be amazing.
absolutely. So I think clinicians who do research, I mean, people who spend the time in research, first of all, they like to do, there are personality types like me where, I'm not fulfilled in life unless I'm thinking about new questions and trying to help answer them. So I didn't realize that's who I was until much later in my clinical career, actually not much later, but towards the end of my fellowship. So as a clinician, I went through medical school, and then I knew that I liked communicating with patients. Like that was my skill set, is really the talking about very difficult things that patients were going through and trying to get consensus and shared decision making with patients and families. Also knew I didn't want to be a surgeon because I didn't like standing in an OR for so long. And so I went into internal medicine knowing that there would be opportunities there. And I matriculated at University of Chicago, where I did my internal medicine training. Then very early on in my career, I was taking care of patients in the hospital on the hemonc floors. And I realized that a lot of patients would express a concept called decision regret. So they had started treatment, either chemotherapy or got a big surgery, and they felt like they wish they had more information before um, they did that, because they may have decided differently, knowing now, that they're experiencing side effects, that life is difficult. And many of those patients were older, patients in their 80s and their 90s. And I was really impressed by that. Then when I was in the clinics, I would see when the clinicians would talk about, here's what you should do. And there wasn't always shared communication and thoughtful approaches to the conversations. And this was now, I'm older. So this was now, I'm not that, but in my 40s. So this was a while ago when patient-centered communication, I think the principles of patient-centered communication were just not as explicit as they are now. And so because I really cared about older adults and I felt like that was where the need was, I ended up doing additional training in geriatrics. And I was the first person at the University of Chicago who did both fellowships. And there wasn't really a geriatric oncology clinical pathway, even nationally. And so I was one of the few people starting that. And there was a group of us, pretty early career, who started to work together to kind of answer questions together. And we created a group called the Cancer and Aging Research Group, which is still in place and now is 600 people. But so at that time, there wasn't a lot of people doing what I was doing, but now there is. And so through that pathway, I've learned about all the different questions. There's so many different questions, clinical questions that we don't have the answers for, and also infrastructure issues related to ageism and how we think about doing research in oncology that is not
Mm,
inclusive to older adults.
mm,
That sort of became my passion, and that's why I went into research at the same time of seeing patients.
mm,
So I see patients, which I love, and what I do in the clinic really informs what I do in my research career.
Dr. Mohile, can I ask you a question? 'Cause in preparation for this conversation,
Yeah.
I was just doing some. I think similar to you, going down scientific question rabbit holes, if that's
Yes.
the thing. And one of the things that I've known for a while, but sort of struck me in reading some of your work, is if we look at just the pure epidemiology of oncology and cancer, 50% of our patients are above 70.
Hmm.
It's incredibly surprising to me to learn that geriatric oncology, one, is a relatively new field,
Hmm.
given the kind of, I mean, majority of patients are above 70. So it kind of
Hmm.
feels very counterintuitive to me to think
Yeah.
about it as a new field. So that's one thing that surprised me. And the second thing that surprised me is, and I'm sure we'll get to it, is when we say clinical research and geriatric oncology patients are underrepresented,
Hmm.
which is another kind of very surprising fact for me because if they're underrepresented, who in the world is in these trials?
Yes. Well,
Sorry.
we can talk about both those points. So the first one is it's very true, with the aging of the population. There is a growing number of older adults that will experience cancer, and the demographics will shift so that even more of the proportion, the subgroups will be geared towards older age. And it's interesting because, if you, depending on where you live in the country, some clinics are seeing, almost everybody is older. Like if
Mm,
you're a community oncologist in a rural area, almost all patients are over the age of 65 that they're seeing, because younger patients tend to have the mobility to go to an academic center and drive to get the best care, whereas older patients will stay in their community, really, and go to the oncologist that's closest to them. And so the challenge, though, with that is the second part of what you asked is when we're designing clinical trials that establish the safety and efficacy of the treatments we use for cancer, we are not enrolling the same proportion of patients that are older that is comparable to what's happening in the general population. And that is known. In fact, the NCI, National Cancer Institute, just published their data that showed that less than 10% of patients on clinical trials are over the age of 75. And that proportion has not changed over the last 10 years. And there is real infrastructure problems. I think, and it to me, it's, I mean, we're on your podcast, so I'm going to be a little provocative. I mean, and I'm a professor now and I'm tenured, so I can say what I want, but I do think it's ageism. When I talk to people about older adults,
yeah.
they'll shift to, well, what you're learning is also relevant to younger patients. And it's not as important as what's happening to the older adult with cancer. And to me, we should be enrolling older adults onto clinical trials because they're the ones that have cancer. We need to know how to treat, and we need to treat them as they are, with the importance that they have in our society, right? And it's not about learning things that might help other people. And I think that is pervasive.
Yes.
In clinical trials, they're designed to try to make sure that the treatment works with the least amount of kind of confounders. So the people that are recruited are the ones that have limited or no other medical problems, because the goals of the trial are to know if that treatment works, and investigators are worried that, oh, if this person has renal insufficiency or other comorbidities or recent history of cancer, that will interfere with my ability as an investigator to know if this treatment really works. And that's really important. We need to know if treatments work, but the problem is we're getting that data in really very fit patients, either younger or even older patients who are very healthy.
Mm,
And then we don't know when we have the drugs come on market, what is the safety and efficacy for the patient that's sitting in front of me in the clinic who has disability, has heart disease, has renal insufficiency, lives alone, is having trouble taking their medicines, and may not be as fit as the people that are in the trials. And then we're just guessing. Like, it's really crazy in medicine how much guessing we do. It's like we're just like guessing, and my guess might be different than my colleagues' guess. It's like it's like the Wild West, really. And we see this in national databases that show there's significant variability in how we're treating people because we don't have the data, right? We're not creating the trials. So it's like a circular problem, and it's really, for me, I've been working on this problem a long time, and we've been making progress, but it's not like major progress. It's incremental progress.
Can I just say how much I appreciate you saying that you're guessing?
Yeah.
I cannot tell you how much I appreciate it. And I'll tell you why. It's actually the reason the podcast is named what it is. Everyone assumes that the podcast is named The Patient from Hell because I am a controversial patient. It actually, that's not, I mean, sure, I think I show up as a patient who has opinions, a lot of
Which is,
opinions.
you should have opinions. It's your body.
Exactly. That's my philosophy, right? It's like my body, my health, as long
It's
as
your
my health.
health.
Exactly. I am
And
fully,
as
fully embracing
clinicians,
of
we
it.
can't have patients who come to us and assume that they don't have the ability to synthesize information and make decisions. It's just not appropriate.
200% agree. But the reason the podcast is named what it is actually not so much because of my identity, but it's named after a book that was written by a professor from Stanford who is not in oncology or medicine or
Hmm.
healthcare at all. He was an environmental scientist who got diagnosed with a rare disease
Hmm.
and rare cancer. And he wrote the book, The Patient from Hell, How I Worked with My Medical Team to Get the Best of Modern Medicine.
Hmm.
And he essentially, and I happened to read this book very, very early into my cancer diagnosis.
Hmm.
And he essentially argues that clinicians and medicine in general is trained to treat populations.
Hmm.
And all of the data and all the research is done on these cohorts. And it all
Yes.
comes down to which cohort was enrolled in what
Yes.
study and how the research is
Yes.
done.
Hmm.
But when you, excuse me, when you look at it from a patient perspective, you
Hmm.
really are looking at the individual patient.
Absolutely.
And clinicians are not trained to think empirically.
Correct. That is absolutely correct. I think that's a real important point that is important for every patient, but may in some circumstances be even more important for an older adult who that individual decision is based not just on what's in the trial, but it's based on what else is going on with that patient comprehensively. In terms of their health, in terms of their ability to function, and and then it also relies on their goals. And so I'm very honest about guessing and uncertainty even with the patients in my clinic, and I will tell them we don't have the right answers. In some ways it empowers the patient because I say, like, it's not, I don't know what to tell you, like, here are the options I can give you, but what you want in your voice is the most important pathway for our conversations, what I need to know, because whatever you decide is the right answer. We don't have the right answer from the data. Whatever you decide after our conversation is the right answer, no matter what you think. And it's a different framing because it's not like, here's what I think you need to do based on the trial that doesn't even have patients like you in it, which is what happens. And it happens not only for older adults, but those from minority backgrounds, those who live in rural areas, those that have limited access to care, those who don't speak English. It's all of our underrepresented groups. It's very common, and the data that we have is just not generalizable to these groups.
And that's something I really struggle with. And I'm going to link, so I'm just going to kind of draw a picture now a little bit because we have research that's enrolling essentially not patients like me, right?
Mm-hmm.
And you listed a whole bunch of groups of patients
Mm-hmm.
where they really are not represented in the trials
Mm-hmm.
today. But then you have guidelines.
Mm-hmm.
And guidelines, yes, there's a like low, medium, high confidence level on it, but there are guidelines.
Mm-hmm.
And if I understand the little that I understand of medicine is that institutions are actually measured to some extent on how concordant they are with
Yep.
guidelines.
Mm-hmm.
And then we have this like discrepancy between patient goals and system goals. And I do think that, at least my personal experience, sometimes, not always, but sometimes they do kind of butt heads.
Right.
Because sometimes when the empiric treatment that might be beneficial to the patient, or the patient wants something that is not concordant with guidelines, either the system can't actually do it because the data doesn't exist, or because insurance won't cover it.
Right.
So if I look at that continuum of, you start with research and then you end up in kind of decision making, real world decision making, sometimes, and I've definitely been there, it sort of feels like you have to go by the recommendation of guidelines, even if it doesn't actually match the patient goal.
Well, clinicians feel that way, I think, because there's a balance. I mean, and it's very complex, as you've pointed out. There's a balance between what I can do for patients as a clinician beyond the guidelines, or how I, as a clinician, interpret the guidelines for the patient sitting in front of me.
Hmm.
And maybe I will be non-concordant, and I will
Hmm.
get dinged, but I have to explain why. And that's okay because it makes sense for the patient. And it might be because of patient preferences, what their goals are, or it might be because those patients were not included in their trials, or it might be because, the patient is you know, doing well, but we don't have a treatment option for that patient. And yet I know from the small study over here that there's something that might work, and I'm going to fight for that patient, right? So there's all sorts of context around that. I do think that we have to not have systems that eliminate the physician's voice. So if we have systems that say um, that we have to do everything a certain way, or we get dinged, or we're going to lose money, or we're not going to get reimbursed, or that will not help, because no matter what happens, I know that clinicians, no matter what they're doing, for the most part, want to do their best for the patient. It's just how they know how to do it, right? And there are people that have different skill sets. It's a big group of people, but they no matter who it is, and I've talked to many on community colleges. I work directly with community oncologists in my research. They all really want to do their best. It's just how they can do it and what is available to them. The other thing is to have guidelines for those outside areas. So we have guidelines. Okay, this maybe covers 80%, but we need guidelines for the underrepresented groups. And so for geriatric oncology, I helped write geriatric oncology guidelines for the American Society of Clinical Oncology, where we said, when you see an older adult, you should think this way. I know the treatment paradigm may say this, but make sure you're also doing these, what we do tools called geriatric assessment, which capture health status. Make sure you do that, because then you're going to know, okay, does this patient's health, is it similar to the health of patients in those trials? Maybe it will inform what is safe or not safe in the real world. And we've done trials to show that when we do these kinds of things, it actually improves outcomes. And so we should be doing the supportive care decision-making procedures in addition to just our own individual decisions for treatment. But I will tell you, you're right. These kinds of extra approaches are not covered by insurance. So my ability to get doctors to do them is limited until they are, and they're just not. And so people have to do it in their, when they have time, and there's all sorts of implementation issues, which is why I think implementation science is so important. Okay, PCORI really supports implementation science. In our first grant, we found something worked. I got a second PCORI to show, okay, now can we get people to do what I found? And it isn't easy. Like, we're right in the midst of that grant right now. It's not easy to have clinicians do something that's not reimbursed.
So sometimes when we talk about this sort of conundrum of getting clinicians to do something that is not reimbursed, I think part of me feels really frustrated,
Yeah,
because
I bet.
there's something you said that I really want to underscore, because I don't think I've heard it actually, I don't think I've heard it often at all, which is systems need to enable clinician voice. Because we talk a lot about patient voice, right? Patient voice is everywhere. Every pharma company website, patient voice, hospital systems, patient experience, but it's everywhere. Which I mean, as a patient, I'm like, yes, thank you. Like, that's kind of a
Yeah,
given.
and
But
it's important.
and it's important. That's not to underscore the fact that I think the clinician voice, to your point, I actually feel a lot of empathy for at least my oncology team who had to deal with me, because I was definitely the patient pushing for
Hmm.
empirically driven decision making.
Hmm.
And very often I could tell that while my clinician agreed with me, the
Hmm.
system was not actually set up to enable my clinician
To do
to
what was right.
correct. And that it took me a while to appreciate that, because as a patient, you don't always see that, right? Because you're in the
No.
appointment, you're kind
Hmm.
of facing, you're sort of like blinders on a little bit, thinking just about kind of your situation.
And
But
as you
then,
should be as a patient, honestly, the system and the clinician, we have to put the patient first. But you're right. But over time, there are clinician barriers, or there are system barriers that prevent clinicians, in other words, from doing what is right
yes. And I
in
think
many
the
circumstances.
and I think
Hmm.
that it's the what is right that I
Hmm.
think, at least in the last year and a half, and honestly, through a lot of podcast episodes that we've done, I've been spending a lot of time thinking about what is right, right? Because
Hmm.
the way we've defined what is right today
Hmm.
is not patient goals.
Right.
It's just
That's
not,
why
right?
PCORI exists.
Exactly.
Yeah, you're absolutely correct. So I'll just give you the example in oncology. So all of the outcomes historically in oncology clinical trials are survival, which is important to most people, of course, progression-free survival, which is, a surrogate measure and maybe may not be like the strongest endpoint. But things like tolerability, which does include the patient voice, toxicities, which often include a complementary perspective from clinicians and patients,
Right.
they're not always embedded or interpreted. So I'll be at a one of my pet peeves is I'll be at a meeting and they'll say, "Oh, there's 60% significant toxicities, highly tolerable," and I'm like, "Who said that was tolerable?" Like it's just the investigators who said that number is tolerable, right? It doesn't make sense, and the trials. Endpoint design has never been in partnership with clinicians who are actually taking care of a lot of patients in the community
Mm,
and with patients. So it's often investigators who are academic like me. I'm one of them. I'm telling you, I'm one of them. But we have to bridge to the people who are doing the work in the community. I'll give you an example of a framework that I think does work. So I'm an investigator in the NCI Community Oncology Research Program. This is called NCORE. It's funded by the National Cancer Institute. So there are 7 research bases where investigators sit like myself. There's one at the University of Rochester, and I lead the care delivery program in that group. So the research bases come up with ideas, they work with the NCI to get funding, they apply for external funding. But there are community oncology practices that are paid for, apply for grants from the NCI to be able to enroll patients onto these supportive care and care delivery trials that we design.
yeah.
Our protocols cannot work if we do not partner with the clinicians, because I do not know what it means to work in Alabama or some of our SCORE sites, or in Minnesota or in rural Pennsylvania. I just don't know, right? And so we have to engage those clinicians at the design level of when I'm designing a trial,
Mm,
and we also have to engage patients too. And so when we do our annual meetings, we sit and we talk to everyone,
yeah.
and we have the clinicians on our trials as community oncology PIs, and they're informing every step of the process. Because if I were to design a study and put it out there, it just won't enroll. It'll be a waste of everyone's money if I'm not doing those partnerships. Now, on the treatment side, I don't know if that happens the same way. In care delivery research and supportive care, there's a lot of partnership. On the treatment side, it's just much more historically designed. It's a very structured way. We work with pharma, we write an IIT, investigator initiated trial, we work with our NCTN colleagues. How much dialogue is
Mm,
there? We're trying to provide more guidance to people writing trials to do this dialogue, but often people pick protocols, they cut and paste. The old one, it just perpetuates and perpetuates to the next step without stepping back and say, can I do this better? Can I enroll more patients from a minority background? Can I include more older adults? If older adults are going to be the primary proportion of patients in this trial, maybe they don't need to be in the the first cohort because I really want to see if this treatment works, but maybe I get funding to enroll 50 more patients. So I really understand the pharmacodynamics of this drug in this population. And you need to think differently, right? It needs to be innovative. And it's hard to do that in a very defined structure of research, which people are comfortable with and have been successful. And if you're successful in this, if you're getting success in that current system, like why would you change? And it's one of the issues.
Can I go back to something you said about endpoints?
Yeah.
Because something struck me in hearing you talk about it is so far PFS or progression-free survival really has become kind of the surrogate endpoint,
Yeah.
overall survival becoming your primary endpoint.
Hmm.
But then when we're looking at a population that's 18, 90, I struggle with that because I mean, this is not that people who are 80 or 90 shouldn't be looking at overall survival in
Yeah,
5 years.
patients struggle with it too. They're like, why am I going on a treatment trial? This is why older adults don't enroll on other trials because they don't believe those endpoints. They don't care. A lot of patients don't care. I just saw a patient yesterday, 76. He's actually a pretty fit 76-year-old. And I had to tell him, it, we have to treat your cancer because average life expectancy for you is still 15 more years. And he was like super surprised, right? And I'm like, no, you could live to your 90, that's 14 years from now. And if we don't treat your cancer, then that will be your life limiting event. So survival is not always thought of as the most important endpoint for older adults. And that's been played out in lots of research where we're doing trade-off questions. So we've presented questions to older adults and said, if you were to have impact on your cognition with this treatment so that it affects your daily functioning, would you be willing to take this cancer treatment if it were to make you live significantly longer? So the longer life versus the cognitive impairment, almost all older adults will say no. And I just had this discussion with a patient yesterday who was in this decision making with a treatment that was causing him memory problems that would make him live longer, but he just didn't he didn't want to do it. Like, he wants his cognition, right? As we would all. And so the function piece of it is so much more is so important to this population. And it's actually important to all patients. The Friends of Cancer Research, when they've defined tolerability, they include patient function with the patient's voice as part of the tolerability definition. And so the problem is in treatment trials, we're not measuring function with the patient, with patient-reported outcomes or with objective measures, which you can't assess tolerability without that information. So again, when I see clinicians say 60% toxicity, it's very tolerable, I just laugh. I mean, you cannot say it's tolerable. You can say there's 60% risk of toxicity, but cannot say it's tolerable unless you have the patient's voice or some functional assessment.
No, it's totally true.
Mhm.
I really, really wish when I was going through it, I knew this data.
Mhm. Mhm.
And I say this because cognitive impairment, even in my situation, like my
Mhm.
brain has completely changed.
Yes, it
And
has. It changes
it's
with
sad.
treatment. And
And
how much information did you have about that before you started? Not much, right?
there was no
It's not
baseline.
it's not prioritized, right?
Okay.
But patients want this information, and this is where we need research. If you were to start this treatment, 15% of patients have memory fog. It will get better in 5% of those patients. 10% of patients have consistent problems. We don't have this kind of data at a granular level. For older adults that see me, many of it is like, I want to stay independent in the home and take care of my own business. What is the risk that I would go into a nursing home if I were to choose chemotherapy? Or what is the risk I would go into the hospital? I do not want to be hospitalized. We don't have this data. We just don't have it. We don't collect it. So I can't give them those estimates, and that's really important to their
Mm.
informed decision-making process.
So, doctor, can we talk about that? So,
Yeah.
in the absence of data,
Mhm.
how does the patient come to a informed decision?
Yeah, we have to use we have to have real conversations. They have to be real. They don't have to be one way where I'm talking the whole time and I'm telling people what to do. There has to be real honesty in that relationship. And I feel like when I'm honest, people appreciate that. They find it to be helpful. I think that people get nervous when doctors are really like, you have to do this, right? Because really nobody has to do anything. It's really up to the patient. So I can present options, and I do. And I can also explain that there's uncertainty, and I can express empathy when it's a very difficult decision. I'm often counseling patients when there's no good answer either. Like, this surgery is going to be really hard. You might need to go to a nursing home to recover, or you might die. And it's super hard. And I don't know if you'll ever be able to limit it to live at home independently, or you don't choose the surgery, and you'll die from the cancer, right? There's no good choices there. But I think people still value those kinds of discussions, because then they understand when they make decisions what might happen. And this issue of decision regret really comes down to patients who, when nobody told them, like, nobody told me this could happen to me, that I would go to a nursing home. No one told me. So even just presenting, this might happen to you, even if I don't know that it will, or I don't have the estimates, is very valuable to patients to know what might happen. And as clinicians, we have that information. We know what might happen, and we
Mm,
should be at least bringing that up. And so when we explain all the options, then I listen and say, what are your goals? They'll tell me, patients will tell me, and then I'll say, how do you want to make this decision? Do you want to think about it? Do you want me to tell you what I think? Do you want to talk about it with your family? And people will tell me different things. Really, I never know. Like, it's really very surprising to me. Sometimes I think, you'll have 15 people in the room from the family, right? And the patient says, I don't care what all of these people say, it's my decision, right? Or other patients say, I don't have anyone here in the room, but I want to go talk to my 15 friends later, and I'll come back to you. Other people say, doctor, I'm going to do whatever you say. Just tell me what to do. What will you do if this was your family member? So I really
mm,
adjust my communication and how we present decisions to what the patient's goals are, even in the context of
mm,
that conversation.
mm. That was actually very insightful. I
Hmm.
I actually don't think I have heard anybody say that, which is how do you want to make the decision?
Hmm.
Which, to your point, is actually one of the more core questions, I think, because
Yeah.
sometimes as a patient in the room, even though information is coming at you, it doesn't mean that we, like, at least I have not processed information. Like, I almost always was like, I will not make the decision now. I want to go home and think about it.
Yes.
Uh, at least early in diagnosis. But when we were doing like
And can I
both
ask you a
infusions,
question?
sure.
How did your social network members help you or not help you as you were making decisions?
So my entire family showed up from India. So my mom, dad showed up, my brother
Hmm.
showed up.
Hmm.
And at the very beginning of the whole journey, one of my mentors told me to think about the cancer experience like a project
Hmm.
and assign roles to all the family members.
Oh, that's very interesting.
So
Yeah.
everyone had a
So you
role.
took a control, like, I'm gonna tell you how I need your help.
Yes, I
Hmm.
focused on my immediate family. Extended
Hmm.
network much harder. It was also during
Yeah.
COVID, but everything was
Yeah.
kind of funny.
Hmm.
And in my family in general, kind of outside of my personal situation, uh, I'm almost always the person in the family doing the medical research and writing up the questions and like
Hmm.
talking to the clinicians on behalf of the family, etc. So
Hmm.
in my case, in terms of decision making, I was just like, this is mine. Like, I
Yeah.
actually don't want opinions,
Hmm.
and that doesn't mean they didn't tell me their opinions, but
Yes.
for the most part, my everybody had a role, and the medical decision making was very much mine.
Hmm.
Um, and I think in terms of communicating with the oncologist, I had a different diagnosing oncologist and a different treating oncologist,
Hmm.
and I read everything I could possibly read from my diagnosing oncologist
Hmm.
at that point in time. And I remember this moment where he was like, it's been 6 weeks since we diagnosed you. We need to start you on treatment. And I was like, well, where's the research? And he
Hmm.
looked at me and he's like, what do you mean? He's like, well, I know this from, I've worked in healthcare. I know that there is a quality metric that hospitals get gauged on, which is time from diagnosis to time for treatment. And I
What is
appreciate
that
it.
number? I need the number, right? What is that?
Yeah,
No, like, there is some data,
yeah,
like, what
yeah.
supports this, right?
Correct. And I remember him just looking at me being like, well, there's a study in rats. And I was like, well, I'm really glad I'm not a rat. So
Yes,
no,
exactly.
I'm not willing to start yet. I haven't
Yeah.
quite
I need to,
understood.
yeah.
But it was also, that was, I realize this now in retrospect, that it was early stage breast cancer and I could afford to do that.
Yeah. Right.
Right. But if you had a rare sarcoma, you may not actually have that privilege to take that kind of time.
Right.
Right. So it also depends on kind of
But you need your clinician
person.
to be able to explain that. Like, it's okay, you have a little, this is how long I think you can go, right? Just
Right.
base, and what's informing what I'm saying about that versus, somebody else where you have to start or this will get bad quickly. Like, I know this. You just,
And he definitely did. This oncologist
Mhm,
absolutely told me that. In fact, he was like,
mhm,
"Yeah, go on vacation, come back, and then we'll finish the
mhm,
diagnosis." So he was very, very supportive in the sort of major decision making processes up front. But he also took
mhm,
out incredibly long amounts of time to talk to me. I remember
mhm,
this crazy meeting where I think we were there for 3.5 hours or something,
mhm, mhm,
because he had given me the up to date Walter Clover's documents that the clinicians have access to and printed
mhm,
it out.
and going through it.
And we just went like all of them. So he gave me
Yeah,
all everything breast cancer, which meant I
yeah,
had, I don't know, hundreds of pages of reading,
yeah,
which I did. And then I remember this conversation where in the geriatric population there
yeah,
was some data that in the geriatric oncology population, especially for women as postmenopause, you could do neoadjuvant endocrine therapy
right, right,
and monitor uh, the response to that, and then maybe do chemo if you really had to,
right,
or just go straight to surgery. And I remember
yeah,
this conversation with him as if it was yesterday, because I was like, well, I want to do that. And he goes, Samir, you're not 80. And I was like, yes, I
yeah,
understand, but it's a valid treatment decision. It's actually a
right,
valid choice in my type of cancer. And he
yeah,
just looked at me. He's like, well, one, you don't only have hormone positive disease. If you did,
yeah,
then maybe it would be right. But you
yeah,
have triple positive
yeah,
breast cancer, which
yeah,
will kill you in, 2 years if you don't treat the
yeah,
HER2 pathway. But we were kind of in that level of granularity with,
yeah.
with decision making. And I feel very fortunate to have done that, because I don't think I had decision regret. But I also took like 8 weeks to make my mind up. Right? I
Yeah.
took a long time to get to kind of
Well,
a.
it's a lot. I find patients who try to help other patients, like you are through this podcast, have expressed to me this. So, one of my close colleagues, who you may want to interview at some point, is named Beverly Kanan. And she also went through early stage breast cancer. She's in her 80s. She comes to me with me to meetings. She's this really strong lady, and she went through the same process. When they told her she needed to do stuff, she was like, I need to understand it. Right? Like, I'm smart. I'm going to go through it with you. I'm going to come back. And I actually think she decided against some of the recommendations. I don't know all the details. And I'm saying that because she's my friend. And if she listens to this podcast, she's going to be super okay with it. But because she's one of our advocates on our trial. But she went through this too and learned a lot about this. So she sits with patients and advocates for older adults in the clinic, and will challenge in a good way to get the information needed for patients and care partners to make decisions. But I asked you about your social networks because I find this to be fascinating to me about how people make decisions. So again, we only see people as clinicians in that room for a few minutes. Then people go out into the world and they're talking about it to so many people. And what kind of information do those people have? How do they support or hurt? And we just don't know. So I'm getting into now this is what I get to do now, my social network analysis, thinking about social networks and how they support patients, especially older ones who do often rely on their networks in many different ways, instrumental emotional support. Um, and sometimes I hear, older adults say, well, I don't really want this treatment, but my daughter wants me to get it, so I'm going to go do it, right? You hear this sometimes, and the kids are looking, often it's the kids like our age going in and, going in and learning everything. And they're like, whatever my daughter says or my granddaughter says, I'm going to do. And it's a little bit different. And so I'm very intrigued by this. And I was intrigued by you saying, I made sure they did what I needed them to do. Like, I told them what I needed. Other people are like, it's just all this info, and it's, my uncle got this treatment, this is what happened to them. And it's not understanding maybe the basic information like you went to the literature and learned, but that needs to be communicated to the whole, network, not just the patient, because the network is informing the patient's decision even more than the clinician in many circumstances. And we don't even appreciate it because patients will say, I'm going to do this. And I'm like, why did they pick that? And they're not going to say, well, I talked to 5 of my friends, and they didn't do well with chemotherapy. And so I'm just not going to do it. Right. It's not what I don't even have the information as a clinician to be able to help sort that through because they're not telling me what happens outside of the visit. So I'm very interested in how people make decisions with their network members,
It's
with their
fascinating.
social network.
That is fascinating.
Hmm.
I'm so glad we're going down that sort of area right now, because the one thing I can tell you that I learned fairly quickly was when it came to decision making in particular, talking to other patients for me
Yeah.
did not work.
Yeah. Yeah.
It did not work. When soliciting options, very,
Yeah.
very different. Like, I wanted to know what the option set is. Talking to patients, super helpful because it gives
Hmm.
you kind of the different pathways that people went down. But when it came to making a decision, I find that, and this is not a knock on any patient advocate out there.
Yeah.
I think
Yeah.
patients
Yeah.
help other patients make calls all the time. But I personally, for me, just because someone else went through whatever they went through, that does not mean that I
That will have same thing will happen to you.
correct.
Right.
And very often the patients who have the loudest voice are the patients who went through something bad.
Yes. Right.
So what was happening was I began to realize that, like, the information I was getting from other patients in particular was very negatively biased.
Yes. That's really interesting.
And I had to learn to, like, realize that that was happening, because it took a couple of, like, rounds of making a call with that, and I was like,
Yeah.
oh, okay, all right, that's actually almost like a counter to, it's almost counterproductive to kind of what I was
Yes.
wanting to try and do. But
Yes.
then the problem is you don't have data. Like, it's the same
Right.
issue in the geriatric
Yeah.
population,
Yep.
right? I just remember this moment of
It's
like,
anecdotal, right? It's all
anecdotal.
anecdotal. But I will tell you, you went through it with a scientific view, like I need to understand the data. Other patients, you can give them the data, but they want the anecdotes.
Yes,
They
yes,
go with the anecdotes.
yes.
And this is where I think this thing where it's the voice is loudest when something bad happens to you is a very true one, because that's what I experienced with patients. Like I made this decision. Well, why did you make it? Well, all my friends told me not to do this. Even my mother, my mother does this too, like about knee
Yeah.
injections. All my friends told me not to do this one. They told me to do this one. I'm like, Mom, like I'm a physician. Like this doesn't matter. Like this is what the data shows. I appreciate that this bad thing happened to your friend, but it's not necessarily happened to you. But people will use that anecdotal information
Mm,
to drive decisions more than evidence.
mm,
It
mm,
happens very often, and it is a health literacy and education level thing too. But how do we combat
mm,
that as a system? How do we develop care delivery interventions that are helpful for the whole network, not just one person, because the whole network is who's informing that person. Like, do we provide the patient with an information sheet that says, this is what my questions are, here's the person's version of what's happening to me,
mm.
here I'm going to give it to you, tell me what you think,
Yeah.
and do what you said. I need you to give me emotional support now. I don't need you to inform my decision. I need you to help me get to the doctor's visit. Like, I don't need
Yeah.
anything else right now, right?
And it was very, the one thing I'll add is, I think information, uh, I think what I've begun to realize is giving patients information, including myself, is super helpful at specific points of the experience, and then
Mhm,
completely not helpful,
mhm. Right.
because you can go from, like, it goes from, I don't know how to describe it. It's like information is coming at you. You need to absorb
Yeah.
it,
Yeah.
process it, and then what happens is very quickly you go into overload mode.
Yes.
Because what happens is we get so much information thrown at us,
Yes.
is
Yeah.
kind of ridiculous. Like, I can't tell you
Yeah.
how much free stuff I got, and
Yes.
it just sat. It sat in some corner of some box, and, like,
Yeah.
at the end of the experience, I literally took all of it and dumped it, because I was just like,
Yeah.
well, if someone gives me another thing, I
Yeah.
it's
So here's
really
where we
not
can do
helpful.
better too. We can do better is how much information is needed without the overload,
Yes,
right? And where should that information come from?
ex- exactly. And
Hmm.
Google is, I love Google, but oh my God, Google can be so
Yes.
wrong.
And maybe we should provide some counsel.
Mhm.
Google's going to be overwhelming. here are the sites that you could go to that we find helpful. Don't just go to the random, like whatever is giving you some crazy information, right? Here's the trustworthy sites. So we don't do this systematically. Yes, we just give info, right? And
Yeah.
especially you were an information seeker, so you got even extra information, probably a lot
Oh
that
yeah.
you didn't need, right? But you were asking for it. But
Mhm.
someone could have said, look, I know that you want information. Here's going to be the highest priority information. You can also go here, here, and here, but you're going to get the most out of this, right? But this is not how we communicate, right?
I
It's
have to
hard.
share, I'm going to share a really funny story with you because so genetic counseling, I got a full
Yeah.
panel. And the day I was with my genetic counselor was the day my oncologist called me and told me I had cancer in that appointment, which
Oh,
was just
oh my
hilarious
God. That's
in and of
crazy.
itself.
Oh, and
Uh,
hard.
and I think the funny part of this whole thing is the genetic counselor had never had that happen before.
Mhm.
So I like was on the call with my medical oncologist in her office getting
And she was
news.
probably like, "Oh no, what do I do?"
Yeah, she was like completely deer in headlights. Anyway, so
Mhm.
then she walks me through, the basics of genetic testing, et cetera, et cetera. And she looks at me and she's like, the report's going to come out and here are the mutations. And in retrospect, now I know which mutation she was worried about, which was like
Yeah.
P263. She's like, do not Google this. And I was just like, I'm sorry.
You
Okay.
can't tell me not to do that.
What? Plus, when you tell me not to do something, the natural reaction is for me go to do it. Like,
I know
come on, like do not say
exactly.
that to me. So I just remember looking at her, being like, don't
You
tell
know
me
I'm
that.
gonna Google it right when I go home now. Thank you for inspiring me to do that.
I'm like, can I suggest something? And this is like the diagnosis appointment, so she's deer in headlights, and I'm like, can I suggest something for you? This is completely unsolicited feedback, but please, instead of telling me not to Google it, give me a list of things I should Google.
Yeah, that's
Give me
exactly
that
what I'm
list,
saying.
right? Give me
Yes.
the question because then
Yes.
I can put that in context.
Mhm.
So it was just this moment of like,
And I will
huh,
say that even that should be informed by patients. Like, here's where patient input could be helpful. Patients who've gone through it, what were the resources that really helped me make a decision? And these are the resources that provided me with the evidence, but also I could understand them and they were well done and I could talk about it and it didn't scare me. It helped provide hope, which is needed for every circumstance. And so, those are the things where it can, and PCORI, PCORI is interested in these things. So this is where, the patient voice can really be helpful.
we come full
You're
circle to
giving me new
PCORI.
grant ideas.
If you want to collaborate,
Yeah, this is great, because I am doing this network study. So once we get I will have to develop intervention over time. And this is where, we could go with interventions.
done. Okay, all right. Okay, so we have an idea here.
Yes, we do.
On that note, I'm watching the clock and I'm realizing we
Yeah.
probably should start wrapping up. Um,
Yeah.
this has been a wonderful conversation.
Yeah.
I'm gonna wrap up by opening a can of worms that I'm hoping that we don't actually fully open, but
Sure.
maybe just use it as a wrap up. And
Sure.
I'm sorry. I know I should be trying to close it, but I'm gonna put this out there because I did see that you also work on cancer prevention,
Yes. Yep.
and I know that that is an area that our audience cares about a lot.
Yes. Right.
So if you can use that as a wrap up and maybe give like three practical ways that anybody who has not had cancer, so survivorship population is very
Yep.
different, but someone who has not had cancer is trying
Yes.
to live a life of reducing risk,
Yes.
how might they do that?
Yeah, so that's great. I think a lot of the things that we learn are similar for a lot of diseases. So, and I will say it's longevity. The longer we live, sometimes the longer we live it increases the risk of cancer because we're older. But if we have a lifetime of doing cancer prevention strategies, then that will be a more appropriate, that will be helpful. Unfortunately, we don't know a lot. So there are behavioral interventions, and I wish there was more pharmacologic interventions. We're learning, but we don't have enough of those. So behavioral interventions, strongest, exercise, eat healthy, moderation. You don't have to not eat poorly at any time, but moderation, eat healthy. Sometimes people think the more, you don't have to be completely underweight, but being a little bit under the BMI recommendation can there are these the very thin people who run a lot live longer and don't get cancer as much. So that is like the number one goal. And for older adults, it's super important too, especially people who've had one primary cancer and at risk for secondary cancers, to be healthy, don't smoke, moderation alcohol. That's your number one. I will say in aging, we're studying something called senolytics. So senolytics are drugs that we think can interfere with cell division in a way that promotes longevity. So people are looking at it to help people live longer. I'm a little skeptical about helping people live longer. As long as that, if we're helping people live longer with good function, okay, but just having people live longer is not good enough. But we're looking at senolytics to combat cancer, to not only combat cancer development, but also frailty in the context of cancer development. So there's going to be more related to that too. And then, of course, screening. Do the screenings, appropriate screenings. I just turned 48. I got my colon cancer screening. I should have done it 3 years ago. COVID, wasn't able to get in myself. I just did it. I do my mammograms every year. And my husband just went through the same thing. Screening is really important. We'll detect things. And then unfortunately, no matter what you do, there are patients who will get cancer because of genetics, because we just don't know why. It's unfortunate. There is an existential thing that I believe in, like we can't control everything. The world functions in a way that as human beings, we just don't know why, and we cannot control. And we're not going to be able to explain it. And so when patients come to me and say, why me? They want to know why. I can say sometimes we just don't know why, and it's not up to us. Something happens. The universe exists, so we have to move forward with what we can help with. And that's the counseling I give. But I do think there are things we can do. We can eat healthy, we can do those things. Sometimes people choose other options. Like I'm not always eating healthy, but I like to eat pizza. So I do, right? But it's okay. Life is, we can only do so much to our human beings.
The only thing I worry about this podcast now is going to end with eat pizza.
You eat pizza when it makes you happy, but not all the time. That's what you take away from this conversation.
All right, I think that's a wrap up statement.
Yeah.
On that note, thank you so much for joining us. This was such a fun conversation. And I am walking away having learned so much, and I'm sure that's going to be the reaction from the audience as well.
Great. It was a pleasure. Thank you for inviting me.
This episode was supported by an award from the Patient-Centered Outcomes Research Institute. This podcast, show notes, and newsletter is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice, and no doctor-patient relationship is formed. The use of information on this podcast or any materials linked from this blog is at the user's own risk. The content here is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice for any medical condition they may have and should seek the assistance of their healthcare professionals for any such conditions.